So welcome back again to the School of Airway and the complications of some procedural sedation today. Alright, so I get a trauma notification of a stab wound, multiple sites, possible pneumothorax, open sucking chest wound. Alright, patient's found outside a bar. He had slash marks, puncture wounds, and slash marks, almost as if it was like a box cutter slashing the right side of the chest. Patient is tachypnic, tachycardic, no hypotension, chubby obese neck, so can't tell about distended neck veins, and he says he's short of breath. Typically, while he's awake, the usual care I've seen in my last 11 years, not including 4 years of residency, is to just give him lidocaine locally and cut. I try to be humane on this guy, right? Put him on oxygen, put him on a cardiac monitor, BP cuff, no hypotension yet. And instead of giving pain dose ketamine, which I retrospectively should have given, I gave him a procedural sedation dose. Mind you, he had alcohol and breath. He admitted to alcohol use, no other drug use. So you need to be very wary of treating the agitated, delirious patient. That hypoventilation and hypoxia may happen from the acute dissociation if you give a high enough dose. Too fast and too much of a dose. Anesthesia may call because this was a trauma alpha level 1 notification. And anesthesia freaked out when the sats dropped to the 80s. We had to bag him up. And of course, this was not expected. I did not foresee this, and I did not want that to happen to him. I just wanted him to have some relief while we put a chest tube in this patient. All right, minimal air came out, some blood came out, but he still had, wounds to the chest that needed more exploration. But now that he was sats down the 80s, and this is a trauma patient, the decision was made to protect the airway out of my mistake of probably giving too much of a dose and pushing it too fast, IV wise. Okay? We intubated him. Later on, we found that he probably had some communication wounds to the liver from one of his stab wounds, and he was also extravasating at the sites of the puncture wounds to the chest that weren't sucking wounds, and he was actually bleeding into his chest wall, confirmed by the CAT scans with angio that was done. All right. So, out of my experience, please don't do that again. If you know he's intox, he admits to it, please start trying to use pain dose boluses of ketamine. Push it slow over 2 minutes. Sergey Motov of Maimonides has suggested, hey, if you could push it over 5 minutes, even better, and reassess him. At 15-20 minutes, if he needs more pain medicines, maybe give it then. At least I'm taking care of some of his agitation from the shock of being stabbed. All right. And I can prevent some of the hypoventilation, hypoxia that occurred for this patient. He was a one-shot intubation, no complications at that. There was no second or third attempt. It was a one-shot first-pass success. Retrospectively, learned from my mistakes. Probably would use a lesser of a dose, pain dose, ketamine. I probably hold off on the drip. I haven't started any ketamine drips on any suspected traumatic brain injuries. For this patient, there was no injuries to the face or head. But in trauma, a lot of trauma surgeons still hesitant from the old literature about giving ketamine for any type of trauma, especially head trauma, but any type of trauma with some type of hemorrhagic shock. All right, so please come back for another lesson of a School of Airway. All right, again, please be very wary for the intoxicated patient. Ketamine is a dissociative sedative. It can cause hypoventilation and hypoxia if you don't watch your dose. I would probably suggest pain dose ketamine. And if it was the same thing would be for IM if you couldn't get access on this patient because poor access or a violent patient. Alright, I'd probably reduce. I have to consider that. There's no perfect study saying what to give for an agitated patient who's EDP, who's intoxicated. Alright, I probably would do the pain dose medicines and work them up in aliquots. There's no perfect first dose medicine. I'm going to tell you straight up. On a fully sober patient who's in military, who's sober out in the field, or a fully awake patient who is not intoxicated and who's assaulted and got trauma, maybe you can consider the 3 milligrams to 5 milligrams dose of ketamine straight off. But if he has any intoxication from medicines they admits to or can't smell, like benzos or opiates or co-ingestions, be very wary of getting the full 3 to 5 milligram dose IM. Even IV, be very cautious. Push it slow. Give it IV push over 2 to 5 minutes. The 0.3 milligram dose per kilo dose. And if it's 70 kilo average size patient, maybe it's 20 milligrams. And watch and see for the next 10-15 minutes. And if he still needs pain medicines, give him an Aliquots, okay? It's safer. Thank you.